Okay, I think that's most people. There's a few people probably dotting in. I'll just start off though. Say good afternoon, everybody. And I best start with some housekeeping. In terms of this session is going to be recorded, and the good thing about that is it'll be available for you to watch again, and for your colleagues to watch who are unable to attend today. It'd be great if you could put your questions in the chat box, and then it's all in one place. But if you put them in Q&A, that's all. We will hopefully not miss them. Later on, there'll be a link to our feedback form, so we really welcome your feedback and suggestions for future sessions, and anything you'd like to follow up with that you want to follow up offline, then do let us know with that. So far this series, we've been talking. Oh, still quite a few beeps. We've been looking at the innovation landscape over the last months, and where to seek support, what sort of expertise is available, and we're keen to kind of follow this on and give you some sort of practical, some sort of talk about the practicalities today. So it's very much about maximising resources from within the NHS. I think the majority of you are NHS staff who are joining today, which is great. And it's about that sort of end to end. So starting right from, understanding there's expertise right from research right through to innovation, well, end of things anyway. And we're all here to improve healthcare, improve patient outcomes. So like to introduce, I'm Fiona Schaefer, so I'm one of the innovation managers. I cover the southeast of Scotland, and Frances Ramsey is my colleague joining us today, and she's my counterpart in the West. And we're also joined by two great speakers. We've got Dr. Allyson Bailey, who's based at NHS Forth Valley. I've kind of very summarised, maybe talking more about that research and governance side of things. And then we've got Samantha Smith-Garrett, who is Senior Programme Manager at Innovation Programme Manager NHS Lothian, and for talking about HISIS, one of the CSO's regional innovation hubs. And then we'll have hopefully time for some more questions. So do, as I say, post those as we go along. So I'm going to just start off, for anyone who isn't familiar with us. We used to be called Scottish Health Innovations and SHIL, and we've been working in partnership with the NHS Scotland for over 20 years now. And simplest way to describe it is that we are here to inspire, to raise awareness and talk about innovation, encourage people to come forward with their ideas, and then to support those to accelerate and commercialise them. And the goal that we all have is to generate healthcare innovations that have a good impact, improve patient care. And that's a unique role. We were set up very specifically with funding from Chief Scientist Office. Our focus is very much on the commercial strength of an idea, where there can be, there's health economic benefits, and there's a commercial product that can be, or service that can be developed out of the end. And with it ties into, where the goal is to generate a financial return for the NHS and innovator. And in addition to those specific projects, we provide advice to teams that Allyson and Sam are in across the health boards in terms of things like intellectual property, regulatory affairs and things, as well as working on discrete projects. So we've got, we're very much about that, providing advice and support right along the innovation pathway. So, from that early innovation idea, looking at assessing those, and actually evaluation, design, development, and then testing is all very key intellectual property protection, obviously, if you've got something that you can actually package and trade and license, which can lead to, the goal is obviously to lead to a commercially viable product, which enables you to have good products and services that do what you need within and improve patient care in day-to-day clinical or administrative background, behind the scenes processes. This all fits into quite a busy but very strong innovation landscape within Scotland. Not all focused on healthcare, but it has a knock-on, there's a lot of expertise and support, whether it is in, managing big data or sensors with some of the different innovation centres, Digital Health and Care Innovation Centre. And essentially today we're going to be looking at that, what's in-house in terms of what's in the innovation, this research and innovation space within the health boards, and how that kind of fits into that, the idea, evaluation, gathering evidence, preparing for scale up and adoption. And I wanted to just quickly mention the ANYA pathway, the Accelerated National Innovation Adoption pathway, which you may have heard mentioned, and that's very much about focusing on a small number of high impact innovations and building, a clear problem statement. It needs to be aligned with national policy, clinical needs, and part of that process is actually ensuring that there's clear evidence of impact, that there's value, significant transformational potential is quite a key word. So it may not be super innovative, but by the time it's actually ready for that adoption, it's preparing innovations ready to be adopted, following the Once for Scotland approach as best it can, and it engages clinical communities. This is maybe a slightly old slide. There's very much engagement with health boards, and that it's still being developed to ensure that actually you can adopt innovations at scale, which isn't straightforward. And that's generally quite a key theme. Things that when you're trying to do something which has been demonstrated in one health board, there's a number of different things that need to be adapted for new ones. Anyway, without don't want to go into any more detail on that, I'm delighted to be joined by Allyson, who's going to talk about and I'm going to stop sharing now, so that she'll talk very much about the research and development side of things, governance and management, what's research and so forth. So let me hand over to Allyson to be able to share her slides.
Okay, thank you very much, Fiona. I will do the sharing and then I won't be able to see anybody. So can you please tell me if you can see the slides?
Yeah.
Brilliant.
Over to you.
Thank you very much, and thank you for inviting me along. So my name is Allyson Bailey. I am the R&D officer in NHS Forth Valley. I also do a little bit of work for Fife as the commercial R&D manager and for the NHS R&D Forum, all of which probably sounds more impressive than it is, but it does mean that I have been around this rodeo for quite a long time. And what I'm going to talk about very specifically is the governance and management of projects that are considered research. And I'm starting by saying NHS/HSC for two reasons. One is that all of what I'm about to say applies to the HSC in Northern Ireland, as well as to the NHS in the rest of the UK, but also because we are supposed to be working as integrated systems. So it's health and social care, and so not just always specifically the NHS. All right, let's hope that this actually moves forward. So the first thing that's really important is that the word research has a narrower meaning in my world than it does in the real world. It's quite specific. And things that would be considered research elsewhere might not fit our definition of research and therefore might not need to go through all of the approvals and authorizations that research needs in the NHS. So things like audit or service evaluation or service development or surveillance are not considered research, even if you are collecting data, analyzing it and reporting it. Unfortunately, it's not necessarily a digital on-off thing. It's kind of analog. There are gray area studies. So what I would always say is if at any point the words research and NHS occur in the same sentence in your mind, you speak to R&D in your local NHS board as soon as possible, and any delivery teams, so the people who would be doing the research as well, to make sure that it's going to work. There are sort of three things that are used to formally define research within the NHS. It needs to be generalizable and transferable. And everybody agrees with this, but nobody's 100% sure of the definition. Generalizable means that at the end, you will have something, or you're planning to have something that other people can use. Now, that might be a product. It might be just an answer to a question. It's something new that can be used elsewhere. So you could be doing a service evaluation and publish that, and people will say, oh, look, Forth Valley is doing this and it seems to be working well. Maybe we could be doing that. So it's transferable in that sense, but you haven't produced something new that they can make use of. New, again, you're adding to our knowledge. You're doing something new. You are coming up with something new that we didn't know before. And obviously it has to be done to the appropriate academic and scientific standards to make it something that is recognized as research, so that it is repeatable. You have a methodology, people can see what you've done, they can do it again and see if they get the same results. High standard, transparent, accurate, scientifically sound, all of the things that you would expect. And that is the formal definition as it is laid out in the UK Policy Framework for Health and Social Care Research, which is basically the principles, the rules for carrying out research within the NHS. You'll hear two sort of organizations, parties involved in most research in the NHS. The first is the sponsor, and that's another word that has a slightly different meaning for me than others. A sponsor it's basically the body that legally carries the can for the study. They might be the funder, but they don't have to be. They could arrange funding from elsewhere. So it's not like when somebody says, can you sponsor me for a marathon? Sponsor is where the buck stops. They hold legal responsibility for the study overall across all of the sites. And then you have a host site. So the sponsor could be a pharma company, it could be a university somewhere in the UK or somewhere in the world, it could be another organization. And then individual NHS organizations are hosts, and they look after their own site. So you'll have a lead investigator who has responsibility for everything going on there. They have to give approval for that site to take part. There are a number of systems and processes that mean that a study that's taking place across a number of sites in the UK can have these things done once for the entire study. So things like ethics review, because frankly, if it's ethical in Cornwall, it's ethical in Edinburgh. So that will be done once for the whole UK and everybody accepts that. If for the kind of studies, things that we're probably talking about here, if you are doing a device trial, the MHRA would give their approval for that. And again, that's accepted across the whole of the UK. So when you go through the central application system, it will actually tell you, you need to go to the ethics, you need to go to MHRA, you need to go to RSAC because you're administering radioactive substances or whatever. So the system by and large tells you what you need to do in terms of these national arrangements. There will be a single R&D review in England and Wales that's carried out by the Health Research Authority. And then in Scotland, there will be a single review for Scotland, which doesn't duplicate what has been done already, but we'll look at things that are specific to Scotland. For example, our legislation on adults with a mental incapacity is different. So they would double check that it works with our laws. So all of those things are done once, and then all that each individual site needs to do is look at their own sort of costing and capacity. I've mentioned the ethics committee. It's kind of obvious what they do. Although they are called NHS recs, they are actually completely independent of the NHS and R&D. And they are there to act as an advocate for study participants. So they will make sure that the information and consent process is appropriate, that the risk-benefit ratio is such that they feel it's okay to go ahead with it, and so on. And pretty much all studies in the NHS will require rec review unless the participants are only NHS staff and they are being recruited as NHS staff. Other approvals that might be needed, again, MHRA for drugs or medical devices, Human Tissue Authority if you're setting up a tissue bank or something like that, RSAC for radioactive substances. Ignore that list of letters for data and privacy. Those depend on where you are, which nation you are applying to. But those are for example, if you are going to have access to identifiable information, participant information, prior to it without consent. It would go through CAG for England and Wales, PBPP in Scotland, and so on. GTAC for gene therapy, the prison services, and there might be others if you're doing something very unusual. Again, when you go into the application system, it will help you decide who you need to get approval from. And the application system is called IRAS. This is an old slide. This is not the landing page you get anymore, which is unfortunate because it shows you how many organizations are involved. But basically, everything that you will have to apply for, with the exception of PBPP, the Public Benefit Privacy Panel in Scotland, you can do through IRAS. In some cases, you do it entirely through the system. You upload everything and it's an electronic submission. In other cases, you will complete documents within IRAS, download them, and then send them. If you are carrying out a drug trial, a CTIMP, or a combined drug and device study, it's a slightly different version of IRAS, and you would get to that through the Health Research Authority website, but the same sort of rules apply. So R&D approval in Scotland, or confirmation of capacity and capability in the rest of the UK. That is the individual NHS sites saying, yes, we can do that. And what happens there is the sites will get all the general information about the study, and then the R&D, the delivery team, and the sponsor will work together to say, right, what are you expecting us to do at this site? Can we do it? Do we have the patients? Do we have the staff? Do we have the equipment or facilities? Do we have the capacity to do it? What is the financial implications? What funding will we get or not get for it? And can we do that? And once all of that is done, each individual NHS site will give approval or confirm C&C, and you're ready to go. If you make any change to a study, that needs to go through a formal amendments process, and those will generally also require review and approval, unless they're very minor ones that don't involve any changes to activity. I do an entire full-day course on C&C, but it boils down to who is doing what to whom, when, where, how often, and for how long. So if you are a sponsor, if you are taking a study out to sites, that's what you need to be able to tell them. The NHS needs to know what they're getting into. What are all the activities? How long is it going to take? What is it going to impact? How is it going to impact on the NHS's normal activities, on their capacity, and what are the costs? There are a number of documents where this information can be found, and one of the banes of my existence is the fact that these documents often contradict one another. Particularly if you're a site like Forth Valley, we tend to be added to a study late, so there have been amendments, but not all of the documents have been updated. So from a sponsor point of view, it's really important to make sure that the sites are getting full, clear information. From a site point of view, you need to be aware that you need to double check things, because what can happen is weeks or months down the line, you suddenly get the lab manual and it says something entirely different about the blood tests than you thought you were working with from previous documents. All right, so that is the end of what I have to say about R&D approval. I think we will be keeping questions to the panel later, or? Brilliant. Okay, thank you.
Oh, sorry. Rookie error. No, not having my mic on. I'd like to hand over now to Samantha Smith-Garrett to talk about HISIS, one of our regional innovation hubs.
Thanks, Fiona. I'll just get my slides up. Just double checking that everybody can see the slides in full view.
Yeah.
Yep, perfect. Great. Thanks, Fiona, for the introduction. As Fiona said, I'm a Senior Innovation Programme Manager in NHS Lothian and also Health Innovation South East Scotland, which is one of 3 innovation hubs set up by the CSO. I'm going to be talking to you a little bit today about what it is that we do. So the Innovation Hub function is essentially been set up as a model to accelerate innovation in the NHS. And it's a way of being able to bring together industry, the NHS and academia together in what they call the triple helix to deliver productive innovation. So introducing new technology, services or pathways into the NHS requires concrete evidence to show advantage over what is currently available. And it's difficult to acquire this evidence without access to patients or clinical facilities to develop and test prototypes or new models. So this national network of innovation hubs have been set up by the Chief Scientist's Office in the Scottish Government to allow innovative solutions to be tried out in a real world environment and to ensure that they're fit for purpose, and that's clinically, financially and operationally before being brought into use. And they cover different aspects of NHS care, from managing long-term conditions to digitalising services to integrating artificial intelligence or AI and machine learning. HISIS are formed through 3 NHS boards, so Borders, Fife and Lothian, with Lothian taking on the role of the lead host board. And HISIS has a pivotal role in delivering innovative solutions to health and social care challenges, whether that's locally within each individually board, regionally as a regional unit, or nationally. And at the core of our approach to innovation is collaboration with that triple helix: staff, academia, industry partners, and we're also seeing the third sector coming on board now as well. And we work together to identify problems that are faced either by patients, staff, or citizens in receiving and delivering high quality, effective and efficient health and care services. While we also want to maximise opportunities for individuals to better self-manage existing conditions and prevent their occurrence. And most of what we do is support in pre-commercial stage innovations. And Fiona did allude to earlier, there is a newly created Centre for Sustainable Delivery, which is based out of the National Waiting Times Board, and they have developed an accelerated National Innovation Adoption Pathway, or ANYA, and that's been put in place to scale up solutions. So that's much further down the line than what the innovation hubs have been put in place to do. So our vision, like I say, working with staff, citizens and third sector, and our mission is to continually develop innovation infrastructure and expertise in the South East of Scotland over the next 5 years and above, to make it effective, sustainable, and to be a leader in health and social care innovation. These are the 3 regional innovation hubs. So we have Lothian, Borders and Fife in the east. The west covers Forth Valley across to Glasgow and down to Dumfries, taking in the Western Isles, and the north of Scotland is covered Tayside up to the Highlands and the smaller regional island boards as well. And this model was put in place to essentially create some additional capacity to allow people to partner with industry, because it's not necessarily something that NHS has done particularly successfully in the past. with academics based on research that's already taken place and how we potentially take that into getting a minimum viable product. And increasing the quality and the quantity of innovation collaboration projects. So we want to deliver solutions to health and social care strategic priorities, but we also have that economic arm in delivering growth in Scotland. So we work with a lot of SMEs. The role of the innovation hubs. So we want to turn existing ideas and knowledge into tangible products and services. We want to be able to facilitate collaborations. That's through co-design, co-development and co-delivering in that triple helix model. Providing leadership support and that testbed environment, whilst also providing regulation support, access to teams that can help with funding applications, data assets and applications for how that might work through a data repository, and information governance. And it allows innovators to refine their solutions that are going to work for an NHS in Scotland, building evidence, informing strategy and developing thinking to support scale up. And as I mentioned, we're not involved in procurement or implementation of solutions that are already in the market, and we don't provide large-scale business as usual services. So that is much more on that ANYA pathway that we mentioned earlier. What we can support is project management. We have a team of project managers that are able to provide you with some support. We have some dedicated information governance support that can help with things like NHS IT security, the creation of data protection impact assessments, security, and various other IG documentation. We can help with being able to facilitate application to the data lock, which is the South East region data repository, or a safe haven type environment. We do have some access to legal contracting and agreements that we can provide support with, and obviously access to the 3 health boards within the region. This is just some of our team. I need to update this slide. I think we're missing a face on there, but at the moment our team is headed up by Professor Tim Walsh. He's the Director of Innovation in Lothian and HISIS. Myself and Graham Cummin as the Lothian Innovation Champion, and we have a team of project managers and also a project support officer as well. That is just the immediate team in Lothian, but there is also capacity within Borders and Fife, which is growing as well to help support local innovation activity. This is just a flavour of some of the projects that we currently have on our portfolio. Some of these projects have come through CSO funding to run competitions where we basically will define the challenge in the NHS and then go out to industry to help us solve those challenges. We also have some projects which are much larger. So we have, you can see there, Medical Drone Delivery Network, which is actually a national Once for Scotland project, first of its kind, looking at what that could potentially look like in Scotland, and that has all 14 territorial health boards and national boards signed up as part of a large Innovate UK funding grant. So we've got a various range of different projects on our portfolio with various different funding attached to them. Just wanted to put up a couple of slides here in terms of what we think is important prior to undertaking a new innovation programme or project. And what we found is that we really need to understand what is going to create value, added value back to the NHS. So it's essential to establish the need for an innovation and have a clear understanding of that value, of what the successful innovation would provide. And that value could range, a variety of perspectives, including efficiency, effectiveness and quality from a service perspective. improved experience of care from a patient or public perspective, or commercial value from an industry perspective, and a clear understanding of the anticipated value from setting and solving an innovation challenge form the basis of what we call a value proposition. And this table shows some of the key principles for establishing whilst creating that value proposition. So there's several frameworks that have been proposed to help guide innovation development. I'm just going to pick one here, which we use quite often within the Innovation Hub, and it's the Double Diamond, which was developed by the Design Council. And an advantage of this approach in health and social care is that it's user-focused, and the two diamonds represent a process of exploring an issue more widely or deeply than taking a focused action. The key stages here are on the right-hand side of the screen. So discover, that's in that first diamond, and that helps people to understand rather than simply assume what the problem is. And it involves speaking to and spending time with people who are affected by the issues. We then move into define, which is the insight gathered from that discovery phase, and that can help define the innovation challenge in a different way. We then move into the second diamond to develop, and that encourages people to give different answers to the clearly defined problem and seek inspiration from elsewhere while co-designing with a range of different people. And that takes us to the final delivery outcome, and that involves testing out different solutions at a small scale, rejecting those that will not work and improving the ones that will. So a key principle in this process is that it's iterative, it's non-linear, and it may need to revisit ideas and/or solutions on multiple occasions during that innovation process to get something that is going to work. The status of an innovation is usually described in relation to technology readiness levels, and this is the scale on the screen here. Now, some innovations will be managed throughout the innovation life cycle, and others could be pushed to the NHS or social care systems that may have been progressed along that TRL pathway and be at a later stage. So the innovation hubs may also specifically seek solutions at a later stage of development, for example, in relation to anything that's perhaps been commissioned as part of a particular competition or challenge funded through the Scottish Government. And the challenges, methods, complexity, costs, and potential value of working with an innovation is strongly influenced by the TRL stage of development. So HISIS tend to work in this area. So we focus on innovations from identifying the challenge stage at TRL 1 through to the early adopter or first market stage at TRL 6 or 7. When we get to TRL 8 or 9, that's generally where, again, we would be expecting the ANYA pathway to pick these up and be creating business value cases, which they have a team of people who are trained to do so. And that's a whistle-stop tour to the HISIS Innovation Hub and some of the work that we do. There is a variety of information on our website, which is hosted on the Edinburgh BioQuarter, and happy to field any questions. Thank you.
Thanks, Sam. Oh. So we're now on to opportunity to ask any of us questions, but particularly our speakers we've got today, based on what you've heard or other things or things that might not have been addressed.
So, hi everybody. There's a couple of questions that have come in round about funding, and as an NHS employee, people are wondering if they have access to a particular fund that's set aside for innovation, and when's the right time really to try and apply for funding, which is, I guess, a chicken and egg situation. Anyone want to take that?
So I can answer from an innovation side, and there are no protected funds, given especially the current fiscal pressures the NHS is under. We're seeing that from Scottish Government. We're probably likely to see a lot of hold on funding. So I would not bank any money on having a little secure pot you can dip in and out of. I think we'll see a lot of changes in that aspect. There are several big organisations such as Innovate UK that run calls quite regularly, and any sort of funding opportunities we would anticipate seeing would be from external routes, not from within the NHS, but the NHS would more than likely be a partner within those applications with an industry collaborator or a university or higher education institute. But that's more likely the funding route going forward that will be on offer.
And round about research, Allyson, there's a question came in around about like kind of clinical studies and commercialisation of the idea. How you go about that with regards to prototypes, CE marking, that kind of a question.
Okay, so this is where things get woolly. So the development of a prototype is not something that would come through me in terms of research. So what we often see is somebody, a physiotherapist, thinks, I don't know, that's a really stupid way to put something on somebody's leg, and they lash up something new that works better and then works with it. Once you reach the point of, okay, I need to gather some data on how this works, does it work, is it acceptable to participants, and so on, then that becomes a trial of the device, and it would come through R&D for approvals and so on. CE marking is, you can carry out a trial of a new device or a new product that is not licensed or CE marked. If it is considered a medical device, you would need to get the approval of the MHRA to do that, except, and I'm not 100% on this because it's not something we've ever done, if it is being sort of proof of concept tested within the organization that developed it. So if one of my physios comes up with something and several patients say, yeah, we'll try out that knee brace, we don't need the MHRA for that. Once you're into something that's considered a research study, as I described in my presentation, it would have to go through all the other R&D approvals. That was kind of a long way around. Did that answer the question?
Well, I think so. I think as you say, it is very woolly, and each kind of idea is usually assessed in its own merits. There's something come in as well that's talking about, it's really good to see the value domains being incorporated into the value propositions. I think this is maybe one for you, Sam. They were wondering if the benefits profile is shared with organisations thinking about ANYA or other partners. I don't really...
maybe invite him to come in and see exactly what we're looking for from that question.
Yeah,
okay.
I don't know if they want to add something, but one of there is a document that's been put together by the team behind Scotland Innovates, Adriana Romley and Dave Beattie and colleagues, which actually which is another, just is one which I think what Sam and the HISIS team have described has gone into a little bit more detail to really help both companies and innovators within the NHS understand to really hone down what they're actually looking for, and if you can be clear with that. But I'm guessing my interpretation of the question was, how does it feed in? How do they connect together? And I think there are some, those are, I think, so a set of key domains which are established in a number of, and you see those across a number of different avenues. And I couldn't quite quickly enough. I'll try and share there's some documentation on the Scotland Innovates website which kind of relates to that. But happy to follow up with the person asking that question.
And I think the idea, Fiona, is that by us getting companies to think about what the value proposition is at the very start, in addition to obviously the clinical services, is that when it gets to a point where you're looking at business cases, then they will already have a lot of that, because what we've seen is, particularly from some of the earlier stage things going to Anya's, a lot of that work maybe hasn't been evidenced or thought about when they're going to do their assessments. So whilst we bring the value proposition in at an earlier stage, we hope that we can build that up through any pre-commercial development work to allow us to be in a better position when we get to that. Right, okay, we've co-designed something, we've tested it, we've got some evidence, we've evaluated it, and now we're pushing it to that adoption team that can then delve further into a lot of those kind of benefits profiles.
Okay, there's another wee question asking about what percentage of innovation pre-commercial procurement projects move to scale? Is there an 80-20 rule that we can use to pre-secure funding using OBCs to prevent stalling and failing because funding can't be found to deploy and scale up a solution?
Oh, that's one for CSO and Anya, but I can only speak on behalf of the South East, and we're really still in our infancy. So our team's only been established for about 3.5 years. And given in the middle of that, we had a global pandemic, everything was put on hold for 12 months. So as the Innovation Hub was really just establishing a lot of processes, etc., we had to put everything on hold, got redeployed, and then had to reconvene and start. And actually getting capacity within clinical services was the most challenging part. We do have a number of routes, particularly through CSO funding and things like innovation fellowships, which are releasing clinician times to be able to work on innovation projects. But really, we're only at a point now where, and I'm speaking on behalf of the South East, I know that the West have been going longer than us, is that we're really just entering phase 2 of a lot of projects and still doing that development, prototyping, gathering evidence. So it's difficult to give you an exact percentage, Carol, what it is. I'm not sure what OBCs are, pardon my ignorance.
Yeah, I don't know either.
Is it an organisational business case?
Outline business cases,
Right.
yes.
Outline. Thanks, Carol. So yeah, we're now seeing again at the moment where we have one project which we're probably getting to business as usual in one of our services. That's our long COVID project. There is obviously issues at the moment where, you know, we were already being asked to save 3% savings. That's now increased to, I think, 7% in the NHS. So how do you save money? So a lot of what we're doing now is looking at really where we can find cost efficiencies, and are we actually able to spend to save when we have such restrictions and budget cuts? That's going to be a real challenge over the next couple of years, because we don't know where the money will actually come from when services are being asked to make real cost efficiencies in how they operate. So that will be a challenge.
Yeah, there's some questions about commercialisation and if you need clinical studies to get your product used commercially, and how's best to kind of go about that, who to contact, etc.
I'm not sure who wants to take that one. Clinical studies is not my bag, so
Give me the question again.
Just really talking about what makes a project commercially viable, and if you do have something that you think's a good idea and you've got some clinical studies, do you need to have clinical studies basically to go ahead with the?
Okay, commercially viable, I can't answer. Clinical studies, probably you could get away without them, but you will find it difficult to get anybody to pick up your clinical device if you don't have evidence that it actually works. So therefore you need to do the study to collect that evidence, and also to see if there's anything that needs to be tweaked or improved on it before you try and sell it to anyone.
Yeah, possibly I should, it's in a sense, is it commercially viable? It comes back to, it may be commercially viable somewhere else, but if you're looking to introduce something to the NHS, you need to make sure that it's relevant, and that's where the the value frameworks and it's looking at, it may be clinically effective, but probably the NHS might need more than that, and the NHS may not be the right customer, certainly not the right first customer. So establishing something that's commercially viable, there's a number of different avenues to do that. Obviously that's the expertise that we bring to projects, but there are a number of accelerators for startups and for academics looking to commercialize new innovations. But I mean, even reading this morning, NHS is one market, one healthcare market. It could be it's the relevant one for you, but and if you're working within the NHS and you have an innovation to improve care, or the processes and how you do your work, then obviously you'd be driven to make sure that works. The challenge is whether it will fit, and it is a very challenging time. So I noticed one of the questions kind of while I'm already was talking about intellectual property, and again I touched on it right at the start. Intellectual property is one part of how you might protect a new innovation, and certainly it's advisable to talk to somebody within your health board, within your research and innovation team, if you think you've got something that might be protectable and it's been developed in the course of your work and it might be owned by that health board. We can certainly advise on that, but the reason we sort of talk about keeping things secret before you start to talk to people is that in order to protect a new idea with a patent, which protects how something works or how it's made, that needs to have been secret and not been publicly available anywhere in the world before. So that's when there's a lot of talk about IP and secrecy, it's relevant for certain types of intellectual property protection, maybe not everything. And it's not the be all and end all for some types of innovations. It will depend. I don't know if that's answering what the questioner intended.
I think it is, and I think we're, in the interest of time, we're kind of running slightly over now. So if there's any other questions, we'll get back to you following on from the webinar. But a lot of thank you for your time coming up in the Q&A as well, and just how to access the hubs, which we can help with. So thank you.
I'm just going to finish off with a couple of quick slides. On our website, we have a consultation form you can arrange to arrange a short call if you've got any questions you'd like to follow up from today. Also, we can kind of signpost you if you're not sure who to speak to. You can also sort of submit your ideas if you've got development further and you want us to look into those. And as I say, we liaise very closely with the research and innovation teams, the innovation hubs across the country, to make sure that it's not reinventing the wheel. Our next webinar is in March, is focusing on medical device regulation and the perspectives of a notified body with BSI. So it'll be an opportunity for those of you to understand a bit more about what that means. Finally, you can sign up to our newsletter and keep in touch with the usual social media. I think that's also for the innovation hubs. It's worth signing up for, to keep in touch with your local innovation hub that way as well. And we hopefully will hear from you, and thank you.